A warm welcome to everyone for this Centre for Population Change / Connecting Generations seminar. I'm Athena Vlahandoni, based here in Southampton, and really delighted to welcome Dianna Smith from the Department of Geography here in Southampton, who will talk to us about a project on food insecurity or security, whichever side we want to talk about. Dianna is well known to a lot of you. She works at the interface of so many different things to do with health and social inequalities, but she's also a fantastic academic in terms of liaising with non-academic partners, and I think that is a theme that comes through all of her work. I have to say that, Dianna, because not everyone is successful in doing that in academia, so we are delighted and honored to have you. You have about 40 minutes, 35 minutes. The floor is yours, and a warm welcome again. Thank you.
Thank you, Athena. That's a really kind welcome. I feel like I could have that every time I do a talk. I would feel so much happier right before I start. I'm really pleased to be talking about this today. So I was trying to figure out what aspect to focus on with this particular project, which I'm going to try to remember to look at my actual camera rather than the second screen that has my slides on it. So apologies for that. This is a project funded by NIHR Applied Research Collaboration Wessex. And again, if those of you who know me are not surprised, it's about food insecurity. And I can see that
Dianna, sorry, we can't see your slides yet.
Oh, I'm sorry, I still have to share them.
It's okay.
Rookie error. There we go.
Thank you.
Okay, hopefully you can see them now. Now, back to where was I? This is funded by NIHR ARC Wessex, so that's based across Wessex, as the name suggests, which is a bit of a waffly geography, but roughly Hampshire, Southampton, Portsmouth, Dorset, Isle of Wight, and so on. And it's a project, it's a group which is funding specifically research that is very much integrated with practitioners and with people working outside of academia. So this definitely speaks to my interest in terms of making sure that we're doing work that is reflecting the kind of questions that need to be answered. So when I was invited to do a seminar, I thought, well, I could do something just about the project, but I feel like I spend most of my life talking about food insecurity, which is sad. And it's been 20 years now of doing work around food insecurity. So clearly the problem's not going away. But I thought I'd focus on one aspect of the methodology of this kind of large project, which I'll talk you through in just a moment. And as I was saying, Elizabeth Taylor is, again, you can see her noted here on the slides. She's also in the room, so she could answer some questions around this, because the work I'm presenting is what she's completed as part of her role as a research fellow on this project. So this is in collaboration with Professor Nazreen Alwan, who's a professor of public health. I'm a health geographer sitting over in the School of Geography and Environmental Science, but I do most of my research, again, around public health applications, and very much collaboratively developed with colleagues outside of academia. So this project in particular was heavily influenced by Ravita Tahim and Sarah Crawford at Southampton City Council, just to name a few. As well as our colleagues at Hampshire County Council and then Dorset Council as well. But Sarah and Ravita were the two kind of key contributors in terms of what this needed to look like. And this project emerged from an interest to think about, with all of the increasing knowledge about food poverty, which you've probably seen in the news, around food banks that are being opened and other food aid interventions, the key issue that we have is that food aid interventions like food banks, food pantries, all these various places where people can go and either pay a little bit of money and get some food or get free food altogether from a food bank. A lot of those are being funded in part, perhaps indirectly, not just through charities, which is what we tend to think of, but actually partly through local government as well. So this question is raised about, well, what do we know what's actually working for people who are food insecure? And I'll probably back up a little bit and give you a few more definitions around what each of these different terms mean just briefly. So food insecurity, and what I'm focusing on here is household food insecurity. It's when people living in a household aren't able to meet their dietary needs and requirements simply by going shopping. They're having to get extra help from somewhere in the form of usually going to a food bank, which is extremely limited. So we hear about food banks all the time. But the reality is, if you go to a food bank, you have to get a referral. So you have to ask someone for some help, usually a school or a nurse or a GP, someone in a position of relative authority. Tell them that you're struggling, you need help, and you get a voucher to turn in at your local food bank. We've got 5 main food banks here in Southampton, led by Southampton City Mission. There's one each day of the working week, and they're open for quite a bit of time. but you're limited to how often you can use a food bank. If it's a Trussell Trust food bank, which is the main provider across the UK, you're limited to maybe 3 times per year. Southampton City Mission has increased their capacity to allowing people to use it 5 to 6 times a year. But it's still not a lot of time, and it's 3 days worth of food at a time typically. But you might get lucky. You might live in the New Forest, where I do, and the local food bank in Leamington is far more generous and gives you a week's worth of food. But you still have to go through a referral process, and there's still very little choice about what food you're getting as a result of this. So what we were really interested in as part of this is that in local authorities and in kind of wider national policy, there's a desire to move people on from just using food banks to thinking about other resources to increase household food security. And one option is these what's called higher agency interventions, like food pantries or mobile food larders. So I volunteered a mobile food larder near to where I live. It, as the name suggests, drives around and people go in and they pay a small amount of money and they get a wider range of goods. So for example, the mobile food larder, you pay between £2.50 and £5, depending on how much food you're going to get. And then you get a box of goods that includes some fresh stuff, some frozen things, and a lot of tinned goods and things like this, kind of the longer shelf life items. So there's different types of interventions. The ones that we're focusing on are ones where people pay a little bit of money and they're able to go shopping in a setting where they go and choose food that's on shelves or in refrigeration or so on. So it's usually 15 items for £5. And that's, again, overseen in Southampton by Southampton City Mission. They're calling it Marketplace. And I'll talk a little bit more about that. But we wanted to focus on these interventions and find out what impact they might be having on populations. Because if there's going to be investment in these various food aid interventions, which are, again, partially coming up from the charity sector, so they're getting food through the kind of surplus food redistribution, which is a whole nother seminar in itself. So I'll try to maintain my focus on this. If they're going to be investing in these, then which ones are going to be the most value for money? Which ones are most worth investing in and supporting? And again, keeping in mind that there's a real postcode lottery of access to this across Southampton or anywhere else as well, because we have to think about where these interventions are placed, who are they most accessible to, and what are the kind of barriers to access. So that was a long preamble, not very much to look at for you, but this slide gives you a little overview of what the project was about. We're very much interested in health outcomes, so diet quality, weight status, and mental health in particular, and understanding the relationship that we know exists between this and household food insecurity. So household food insecurity is not going to go away anytime soon, unfortunately. The first food bank in the UK opened in the late 90s, and now we have thousands across the country. So it's really kind of expanded substantially in response to food insecurity. We know that this is a priority from an NHS and local government perspective, especially for households with young children. Again, best start in life, those sort of narratives we've seen from Michael Marmot's social determinants of health framework is very much maintained here. There are a lot of interventions available. So interventions here being food pantries, mobile food larders. Well, we used to have Sure Start, things like this. But with these various interventions, what we've seen is they kind of crop up where there's people who have the time, who have the capacity, and we have a space to hold it in. So that's why a lot of them tend to happen in churches, because it's a space which is not being used thoroughly throughout the week. But the challenge is the impacts of any of these interventions, like a food bank or a food larder or a food pantry. So either you get food for free or you get to go shopping. Any one of these tend to be unmeasured. So we're kind of guessing as to what might work well for people. With the diet study, what we wanted to do was assess the impact of these interventions on the people using them. Also understand what are the challenges regarding feasibility. So what are the issues that people who are running such services run across, and what are the things we can learn from this that could be used elsewhere when we're thinking about other interventions to support food insecurity? Again, something which is clearly not going away. And this study started in October 2021. So it was running before the official cost of living crisis, but very much in the reality of difficulty for a lot of people. And we also wanted to think about how we could use this information, including with a cost-benefit analysis, which I will not talk about today, to help prioritize what should be funded in local government. And again, this again being co-developed with other councils. Hampshire County Council's priority at the time we were developing this was very much to move away from a food bank model and towards the food pantry model, which is what we've explored here. So these interventions where you go and you pay amount of food, pay £5 and you go and choose 15 items from what's available that week. And the idea is that by funding the most effective interventions in terms of the benefits to population health, then it would be the best investment for local government and improving the diet-related health and well-being of the population. So here's the overall objectives of the project. I'm not going to go into this too much, so I've talked far too much already, but the key thing I'm going to talk about today is assessing the feasibility of the projects. We're doing this through surveys, so repeated surveys with the same households, so a very short-term longitudinal study. And then we're also doing interviews with clients of the food pantries in Southampton, and also with people who are the service providers, so people working in the sector, so either working in local government and making decisions about what needs to be funded, or people that are running the services and talking about the challenges they're facing in maintaining these sort of services. We do have some health economists from the University of Bournemouth who are going to be helping us with the intervention cost and doing some aspect of cost benefit. And the overall outcome is to develop a toolkit that councils can use or local interventions can use to find out what kind of impact their offering is having on households. And this is very much something that I've seen from wider work here in the New Forest and elsewhere. Talking to food banks, they want to know, is what we're doing making a difference, or is there something we could do differently? So we do a lot of mixed methods work in this space, collaboratively across third sector, public sector, to find out what works well and for whom, and how can we capitalize on that and invest more in those sorts of services. So this is a really good quote from one of my colleagues who works in food aid that I like, and he said very clearly, well, Diana, the thing is, food aid wasn't planned, but it's where we're at, and we're in a very much reactionary phase where we open things, we do things when we can. But what the charities want to do, and what they very strongly talk about, is they want to move people out of needing support of food banks and into slightly more dependence of food pantries. And then hopefully, in the ideal situation, everyone's able to just go shopping and choose exactly what they want from a grocery store whenever they wish. So to have household food security. Again, what we're doing here in DIET is to understand what works well for whom, and our particular population of interest are families with young children, so families with children under the age of 12. We want to be able to take what works well and then replicate it as much as possible. The two main pantries that we're dealing with in Southampton are Southampton City Mission Marketplace, which is this one here, and then Southampton Social Aid. And Southampton Social Aid is really interesting because they have faced exactly that kind of challenge around infrastructure, and that they were at one point running 3 different sites of the food pantry 1 day a week. But then Unity Brewing Company, which hosted their site on a Thursday morning, closed down. So they've since lost that particular site where they can host a food pantry for people. These were really great to be involved with. And again, they worked with us to develop a survey that their clients would be happy with. We also worked with members of the public and people who have lived experience of food insecurity to develop the surveys and the interview guides. And I'll talk a little bit more about what goes into that later on. But I also want to highlight the kind of these key issues we've got coming out already. So surplus food, so-called surplus food, which is the things that come out of the supermarkets that there's maybe mislabeled or there's just too much of, is a challenge. And it's a challenge because there's so many more charities working in this space that there's a lot of competition for what food is available. So for example, it used to be that if you worked with one of the food banks, for instance, they would have really strong relationships with the local supermarkets. They go and pick up food that was left over every day, bring it back to the warehouse, redistribute it. And there's a national charity you might have heard of called FareShare that does this on a very large scale. And they'll pick up things from larger centers and then again redistribute it across the spaces. What's really interesting about volunteering outside of my research space, but volunteering at a food larder, is to see the kind of difference in the type of food that comes through and how one week might be real feast and you have loads of amazing stuff, beautiful fresh produce, and the next week is quite a stark contrast where you have a handful of tinned goods and suddenly we're having to charge everyone the same amount of money because there's so little food to go around that we can't have a larger box for a family of 5 and a smaller box for an individual person. So there's a lot of variation in the system. And this kind of precarity in the resources available to the responses to food aid is really interesting and sad to me, because this is a service which is built up around trying to address precarity in people's lives, the uncertainty around how they're going to eat well. And then the response in itself is also uncertain. It may have to close down because a site is lost. They may not be able to open because there are insufficient volunteers or there's no one to pick up the food that day. or it might be an issue of supply. So is there enough food in the system? And you'll often see these narratives around how, oh, isn't it fantastic? We've got extra food with food waste. It's going to people who need it most. Well, no, because actually what we want is people to be able to go and buy what they want, when they want, and make their own choices. And that's why the food pantry model is much more appealing. But when we're still relying on donations largely, or food coming in from fair share to supply it, it is a challenge. Anyway, I know I was going to go off on that tangent at some point, so that's done and over with at least. What we've got here is some of the early results from our study. So I haven't included any major qualitative results from the survey, but these are some quotes that we've had. And Elizabeth, again, who's in this meeting with me, we will go and sit in these spaces and do the, sit there with people doing the surveys, or just be around if they have any questions. And the kind of comments they make to us in passing, these are from the formal interviews, but these very much align with what people have said to us. Things like, this food club, being the food pantry, is great. It's a godsend veg. So we're getting all this kind of anecdotal stories about what has gone well for people. And beyond that, the kind of other side of this is creating a better sense of community. So especially with Southampton City Mission, is an established food bank. They've been going for a lot longer and have a really great resource of volunteers and spaces to use. And they wanted to make their spaces really welcoming. And they were able to do this by having a place for tea and coffee. You can sit down, have a chat. They often bring in people like social prescribers, volunteers from Citizens Advice, to give people this kind of wider signposting around how to improve their situation, benefit maximization, and so on. So it's not just a place to come and get cheap food. It's also a place to kind of make some new friends, build a community. And we've definitely seen this over the year going to the different sites, but also to just gain more information, insight into what resources are available. So the next thing that came from, again, some local government colleagues, because I said to them, well, what is it that you need to know? And they said, what we need to know is where we need to put things. So this aligns with another piece of work I've done that I'm not going to talk about today, which is kind of an alternative to the Index of Multiple Deprivation score, just around food insecurity. This was also funded by NIHR, Applied Research Collaboration Wessex. And the map here, the lovely pink map of Southampton, shows the the risk of food insecurity in different areas, where the darker areas have the highest risk of food insecurity compared to those that are lightest. Not too surprising, those of us near Southampton. It looks roughly like we'd expect it to in terms of income. And the score includes factors that we know contribute to food insecurity. This has been published in December 2022, such as mental health, benefits claimants, people with no qualifications, and so on. We've also included distance to the nearest medium or large grocery store because, well, as someone who's done work on food deserts for years, I can't resist it, but also because, again, people were telling us how difficult it was to buy food that was affordable in the small corner shops. And there's some other interesting work in there as well, but I'll try and stick to this. The little black squares in this indicate where there's food aid available. So you can see there's a few places where there are gaps, but beyond that, remember that each one of those black squares may only be open for 2 hours on a Tuesday. So it may be all well and good if you've got one in your local area, but if you can't get there because you're working one of your 3 jobs, which again is something we hear quite a lot, people working multiple part-time jobs, then it's really challenging. So local government wanted something that would help them to identify where to put things. So it's the kind of what works well and where do things need to go. And I just added a note that academics here, what our contribution can be is being very responsive to these kind of requests. So we do things like develop undergraduate dissertations and master's dissertations to answer discrete questions around this collaboratively with local government, and then are able to build up a picture of what's happening in Southampton, in Dorset, and wherever is applicable. So this is very much the aim of what we're trying to do. We're using a range of methods in DIET, which has got about 6 months left on it. So we've done some systematic reviews. And then Elizabeth is leading on the quantitative analysis. So the statistical modeling of what health looks like right now using small area estimation, I'll talk about in just a moment. And then we've got these longitudinal surveys. So we're asking people to complete surveys up to 4 times. Currently, we have a few people who have completed 3 surveys for us. And the first time point is before using the service. So we'd go into the food pantries, spend time in there, get people to complete these short surveys, and each survey they complete, they get a £5 Tesco voucher as a thank you. And we had them do one before they came, or if they were already using the service, to think back to the time before they came to start using the food pantry. And again, speaking to people with lived experience of food insecurity, it does not slip their mind what kind of diet quality they had prior to coming to a service. It's a very kind of clear image in their experience of what things were like, and so they're able to answer the survey questions we're posing in their opinion with validity. And then we follow up after they started using the service, 3 months, 6 months, 9 months after using the service to see, has there been any change? And I'll go through the questions just very briefly. So the point of that is to see, is there any change in their diet quality, and their food insecurity, and mental well-being? The cost-benefit analysis, again, I won't talk about today. And then the end result is this co-produced toolkit that has things like a simplified survey, like an interview guide, like the kind of simplified cost-benefit analysis you can do to think about what might be the best approach in your area for your population. So again, we've got 3 main interventions, the 2 food pantries in Southampton as well. There's one called the Friendly Food Club in Dorset. So it runs a scheme called Cookbox, where families are given boxes of food completely for free. It's all families, and they have recipes they can then use to prepare these things as a family. We had difficulty recruiting there because it turns out you need to spend a lot of time with people before they want to do surveys. Again, that makes a lot of sense now. We expected this to begin with, but we wanted to have a slightly different intervention, but again, one that wasn't just about getting free food from a food bank. And we wanted to find out more about people's experience of each of these as well. So that's why we have the interviews alongside the surveys. So again, just the kind of reminders of what it is that we're asking through this. So far, we've got about 97 people who have completed at least one survey for us. 52 have completed at least one follow-up. So we've had a really good response rate considering, which I'm very pleased about, because again, this is a population which do not tend to engage quite so much with research. And it took quite a bit of time from Elizabeth Nidda, who's another research fellow in the project, and I going to sit in these different settings, and people to see us and become familiar with us and be happy to do the survey and get the £5 Tesco voucher. We've had an interview with 15 participants so far. That's clients of the food pantries, as well as 3 service providers. And we're aiming to get another 5 interviews with clients to find out more about their experience of using these spaces and what they like and what they wish was perhaps a little bit different. So it's a really good way of getting this information. I put in here that data collection is messy, and that's really putting it mildly. Elizabeth has done a brilliant job of bringing together data from these different types of interventions, which run on different days. Southampton City Mission Marketplace is restricted to people in the immediate geographic area, whereas Southampton Social Aid allows anyone to come in who wants to. So there's a slightly different format in each one of these as well. And Southampton Social Aid doesn't have the space to have people sit and linger afterwards and kind of have those informal chats with volunteers, whereas Southampton City Mission sees that as a core part of what they're achieving, is they want to have that engagement. And so it's been interesting to understand that, and it's also interesting from the perspective of understanding how long it takes to collect data. So to have the patience to go and sit in each of these interventions, not patience, I enjoy doing it, to have the time really to go sit in each of these interventions for a few weeks after they open, to then spend that time and become a known person to the clients, the people using the spaces, the volunteers as well. I mean, we definitely had some volunteers who wanted to know, what were we doing there? And why are we in their space? And are we going to be bothering the clients? Which is a completely legitimate question to ask. So there was a lot to learn there that we'll be writing up as part of the work. So yeah, messy data, multiple interventions, multiple time points of collection. Some people filled in their pre-using the service survey and their current one at the same time. So we're keeping track of this. And we'll take account of it. And just know that we're going to have a lot of limitations in the analysis, which is why it's beneficial that our main output is this toolkit. So I thought I have to focus on some sort of method for this particular seminar. What I wanted to pull in was small area estimation. Not sure why I chose this as a good one, but I think probably because it's a little bit different, but it's something that's being used quite often, and it has been used quite a lot in health. So small area estimation is a nice way of saying when you make up data about health outcomes or other things in local areas like neighborhoods. So in this case, we're using lower super output areas, which is the same spatial scale as the index of multiple deprivation score. And what we were trying to do is see, what did health look like before and after these various interventions? So trying to do a little bit of before and after modeling. And specifically, we're looking at diet quality, and the one that we've modeled here that I'll show you shortly is who has their 5 a day in fruit and veg. And that's in the wider population, not just in the population using food aid. Weight status, so BMI categorized into the typical kind of BMI categories we use. So under 18.5, 18.5 to 24.9, 25 to 25 to 30, 29.9, and so on. Mental health, and here we've opted to use the WIMWeb's short form. So for those of you interested in mental health, there are two main ones that are used in a lot of surveys. There's the GHQ-12, and then there's WIMWeb's. And WIMWeb's is my preferred option because it's a much more positively worded question, which you'll see in a moment, or a series of questions. And then food security. The good news is, although my goodness me, for years we had no data on food security in the UK, we did have a lot of work coming out of the US and elsewhere on household food insecurity. And they have a validated measure for food insecurity, which has now been adapted and adopted here in the UK. And it's used by the Food Foundation on their regular surveys, as well as the Food and You2 survey uses an amended version of it too. So the food insecurity questions are here on the slide. In the last 30 days, and again, we've amended that down from in the last year, has you or anyone else in your household had smaller meals than usual, or skipped meals because you couldn't afford or couldn't get access to food? Ever been hungry or not eaten because you couldn't afford to or get access to food? So smaller meals or skipped meals because of this not having access to food, been hungry or not eaten. So it's trying to get around anyone who might be dieting, or not eaten for a whole day because you couldn't afford to get access to food. And there's a follow-up question saying, how often did that happen if you didn't eat for a whole day? So those are the questions we have around food security. And again, this is very much aligned with other surveys happening in the UK. And then we've got the WIMWeb's score, the short version. And you can see here, the wording is far more positive than GHQ-12, which is things like, I've been feeling anxious, I haven't been sleeping. And we wanted to choose something that felt more positive. So I've been feeling optimistic about the future. I've been feeling useful, relaxed, dealt with problems well, thinking clearly, been feeling close to other people, and been able to make up my own mind about things. So we're asking people to answer these two questions, as well as a much longer diet question. And then some further questions around, if you didn't have a so-called healthy diet with lots of fresh vegetables, why? And finding out the barriers through this in terms of, is it because there's nothing in it, there's no shops affordable near you? You don't have the facilities to cook with, so thinking about the kind of structural influence to food insecurity as well. And then we capture some demographic information about the individuals, size of household, whether they're on benefits, if they have any pre-existing health conditions, and so on. So we're using these kind of national surveys as part of this. Smaller estimation, in this case, I'm using a process called spatial microsimulation. Some of my colleagues, like Graham Moon, who was in geography for many years, used a different framework around multi-level modeling. But this one is a way of estimating data about populations where we don't know. So we don't know, for example, the prevalence of obesity in LSOAs across the UK. If you think about it, the last time you were weighed by your GP, in my case, it was probably 10 years or more ago. So we don't have a lot of data to hand, and we have to think of some way of creating this data in a kind of intelligent, informed way. There's a lot of different approaches, but the one that I've always used is called iterative proportional fitting. It used to be called deterministic reweighting back when I did my PhD, but it's changed names because iterative proportional fitting is actually much more accurate and appropriate. But what it does is it takes people from these national surveys where we know something about their health. We know the thing of interest, their WIMWeb score, their weight status, their whether they had 5 a day or not, and so on. And it reallocates each of those individuals from the health survey for England, let's say there's 8,000 in a year, to the probability of living in each small area. Now, of course, we have a lot more than 8,000 people living in the UK. So essentially what we're doing is we're reallocating people over and over again into the population based on matching demographics. And I'll explain that in just a moment. The benefits of spatial microsimulation using IPF is we don't have to have cross-tabulated census tables, or so-called constraint tables, that tell us the things that we're matching people on. The limitations are, unlike multi-level modeling frameworks, it's harder to create confidence intervals around your estimates. That's something which we're working on right now. We already have done. We've already improved on this. So the very kind of basic overview of how this works is you first have to do some analysis on the survey data to see of the variables you have, which are both in the survey and the census, because the census is how we're matching people up to know that who, like me, so Dianna is a woman with white ethnicity, age 40 to 45, married, and so on, whatever the characteristics that are predictive of the health outcome are, you know, what are my characteristics align if I'm in the health survey for England with my weight status, food, and so on, to reweight me into different areas. we need to have the census data. When the great thing is we now have the 2021 census data. So Elizabeth had already written all the R code and now she's updated. So we've got the 2021 data going in. So the first thing you do is the national surveys or the large surveys is you do regression analysis to identify 3 to 4 variables, which we call predictors, that will be able to accurately predict the outcome of interest, so mental health, diet quality, weight status, and so on. The algorithm was first described by Dimitri Ballas back in 2005 in a model called SimBritain, and that's what my PhD was based on. And now it's been coded in R following Lovelace's example in 2016. So that's what Elizabeth has been working on. One of my colleagues who's been doing the same type of microsimulation in health for years is Malcolm Campbell in New Zealand. And I loved this at a conference last summer when he said, well, look, like spatial microsimulation sounds fancy, but basically it's some version of add, subtract, multiply, and divide in various orders. Because again, what we're doing is we're giving people a probability to live in an area based on the known characteristics of the population who live there. And then we have these weights of it, the probability or weight of a person to live somewhere scaled to fit the known population from the census. So the surveys that we're using are, in this case, entirely Health Survey for England so far. So Elizabeth, not we, Elizabeth has done a smaller estimation for mental health, weight status, and diet using Health Survey for England, pooled data from 2016 to 2018. So we have more people that we're using to repopulate the entirety of England. And then food insecurity has been a bit of a challenge because, again, it's not been captured very accurately or very frequently. So the survey that we're looking at to use this is Food in U2, which runs only every 2 years. And it's the best choice, put in quotes. Here's the algorithm. So you can see that what you do is you take a person and their characteristics, and you are taking them from the survey, and you're saying first, what's their probability to live in each small area based on their age group, and then by their sex, and then by ethnicity, or so on. So for example, the things which tend to predict most health outcomes are age, sex, ethnicity, and some measure of social class, like national statistics, socioeconomic classification. And crucially, we have to have variables that are present in both the national survey, like the Health Survey for England, and the census in order for this to work. So I've got 3 maps for you because it's health geography. We have to have this in here, and it shows the distribution of the estimated prevalence of various health behaviors across Southampton because Southampton's were based. So the first one here is the portion of people who are eating 5 or more portions a day. And I've mapped this inversely so that the areas where the percentage of the population having 5 or more portions a day is lowest are in the dark color. So your eye is drawn to this. And those of you familiar with Southampton will not be too surprised, I think, at this distribution. We can see that in the kind of far east and west and south of the city, as well as parts of the east, the proportion of people who are not having 5 a day is lowest. And actually, probably what I should have done here is mapped out those who have less than 1 portion of fruit and veg a day, which we did a few years ago for a larger national study. And again, that was published in 2021 and +1. So you can see here, these are areas where we'd expect to see fewer people achieving that 5 a day. Now, the national average is just over 3 portions a day. So this is not too surprising. But then we move on to the proportion of the population with low mental well-being as measured using WIMWEB. So again, these are people who answered the WIMWEB's questions in the Health Survey for England, and then we've reweighted them to Southampton. And we can see a similar pattern. So there's areas which again have the highest proportion of the population with low mental well-being as measured by WIMWEBs. So in these darkest red areas, these are all mapped using a quintile distribution, so equal categories. We can quickly see the areas where it's worst is, again, some of the similar areas in the far east and the far west of Southampton. And again, in the center here around Highfield, unsurprisingly, is better. And then finally, looking at adults with obesity, so BMI of 30 or more from that pool data from Health Survey for England. And we can see there's slightly more of them, that there's more areas where the proportion is higher, which is over 29.8% to the east of Southampton. So these are the kind of maps that we can create using small area estimation. Validation is tricky. So this is a screenshot from the paper we did on diet at the middle super output area level across England a few years ago. And you create confidence intervals by doing something clever with multi-level modeling, which is what Graham Moon was doing in this case. With our models, we're using the kind of standard approaches of standardized absolute errors. So we're seeing how well the model is predicting things that we already know, the constraint variables, the age, sex, ethnicity, and social class. And so we can look at the internal validation using standardized absolute error or root mean square error. The other thing we can do that I've done in previous papers is aggregating the estimated data up to a known level, say middle super output area or local authority. And we did this in 2012, looking at mental health and binge drinking using Health Survey for England data. That was with Millen Riva. And then in 2011, we did the same thing using census data from New Zealand on smoking. So we estimated smoking and we aggregated it back up to areas where it was known and found that it worked really well. So there's confidence in this approach overall. I shouldn't say confidence because I was going on to talk about confidence intervals and being able to show some level of uncertainty around the estimates we're getting out of this. So how can we be sure that actually the distribution of obesity or low mental well-being looks similar to this in Southampton? Because essentially what we're doing is a geodemographic classification of the population. We look at aligned outcomes. So you might say, okay, well, let's see about, if we don't know what obesity looks like, what about something else that's associated with it? So for example, we've looked at things around with the food insecurity risk measure, which was not done using smaller estimation. We looked at free school meal uptake and childhood obesity, two things which we know are associated with food insecurity in households. So there's other things you can do instead if you don't have the actual data, which if you had the actual data, you wouldn't be doing the smaller estimation in the first place. So the main outputs we're going to have from this project are these kind of smaller estimation maps of before and after some sort of shock like the pandemic. So we're actually modeling this. Here's all these outcomes before, and then what does it look like after? We're waiting on the data to come out for the Health Survey for England or other options like Understanding Society, for example. National Diet Nutrition Survey is another option as well, but has a much smaller sample size. So we'd have to pool several more years together to get a meaningful number of people to replicate for smaller estimation. So just as a reminder for the kind of wider project, the real thing that we're getting out of this is a toolkit that's going to hopefully help councils and help different interventions like the food pantries to have more regular data collection from their clients about what kind of changes this might be having or may not be having for their diet quality, mental health, and so on. Of course, we've got to remember that people's lives are complicated and it doesn't really fit neatly into a regression model. So there might be other factors which are influencing outcomes. But again, the kind of qualitative side of things is very positive that we're hearing so far. People talk about how much they enjoy going to these different spaces, and they are building up their own community. And actually being able to get a lot of food at a lower price has made a positive impact on their ability to have fruit and veg. And the families trying new foods because there's less of a risk when you're not spending so much money on it. So it's good to hear those sort of things coming out as well. We'll be writing all this up together, as well as kind of guidance on best practice around collecting the data. We'll have some documents around supporting impact evaluations and also thinking about the barriers people are facing, like where do you have a food pantry? If we've got a lovely map that shows us there's areas where there's high food insecurity, but nothing there, how do we facilitate something happening in that place? Is there an option like a mobile food pantry or mobile larder to be available? And hopefully the toolkit will allow us to prioritize decisions more effectively. Of course, we'll have conference papers, and we've already got 3 abstracts accepted for Society for Social Medicine later this summer in terms of 5-minute presentations and 1 full presentation, and we're writing up papers as we go along. Again, the outcomes, the actual data on 97 participants is going to be messy. So we're not going to be trying to write that up in a kind of formal peer-reviewed way, but we will be creating other outputs to share with the communities and with the people who are running these services. So videos and presentations and some sort of social media activities, which I will leave to someone else. And then, of course, for the councils, we're going to be creating a short policy brief. So something in a nice 2-page digestible format, and we'll have a launch event. So I want to just thank all of my collaborators in this project, as well as Elizabeth, obviously, who's here, and then Southampton City Council, Hampshire County Council, Dorset Council, everyone who's the food aid interventions, and all of our participants we've spoken to have been absolutely lovely in sharing their experiences with us. And just some references, and that is it from me. So